Right, so you can see the PowerPoint presentation.
Mm-hmm.
Good. And can you see
Okay.
each other? So first of all, can you hear me and see the PowerPoint presentation?
Yes.
Yes.
And can you see all three of us?
Yes, sir.
Yes.
Good. Okay. Then we are ready. So all I'm going to do is teach an hour of first aid in 5 blocks that are pertinent or relevant to us. Just it's only theory, so obviously there's no practical. It's just a more of a conversational piece. But like I've said to you before, when in the NHS, when we do it, we do online learning like this, and then we just go to a practical session to be assessed on the practical stuff. So since you're not taking the first aid course, I'm just telling you something. It'll just be the same thing. So let me set this up. Right. So do we have pen and paper with us?
Yeah.
We do.
Good. So you might want to make notes as I'm talking about things, and you can stop me at any time. I'll just go through the PowerPoint and stop me at any time if you want clarity on anything or if you want to discuss anything, and then we'll just move on as we go. So the objectives of the lesson are to teach you elements of first aid that are specifically related to what you'll do. So since you're coming up to black belt soon, there'll be times when you'll be in charge of groups, or you may have to take the class if I'm ill or if I can't make the class. As a black belt and an assistant instructor, you may have to take the class. So having first aid training might be a requirement at that point. So this is a good way to set the seeds of it. And I know you've both had some first aid training before, so really it'll just be, excuse me, a recap on what you've already done. Okay, are we okay so far?
Mm-hmm.
Mm-hmm.
Okay, I don't know where this cough's come. But always when I talk to James, I get a cough. But I've brought liquid today. Okay, so as I say, ask any questions you want. Stop me anytime you want. In the handout I gave you, where it listed the 4 or 5 parts, they're just some parts I've picked out of a first aid teaching syllabus that's relevant to you within a first aid, within a martial arts environment. So we wouldn't cover, say, drowning, because that's not a martial arts environment, that kind of thing. So it's going to be things like breaks, bleeding, that kind of thing. I've tried to write it so that it's not that the medical jargon has been minimized. But if there are any bits or words you don't understand and you want me to clarify, just say. Okay, so I'm going to start by asking you a maths question, and I'm doing this just to see if your brain is switched on. I don't know why, but it's just a thing to see if your brain's switched on and see if you can work it out. So by all means, write it down if you need to. I'm just going to give you 5 numbers, and then there's an answer at the end to see if you can work it out. Okay, you ready?
Mm-hmm.
2 times 10 minus 10 plus 100 equals. What's the answer?
110.
110.
Correct. Good. That's that out the way.
That's about my limit as maths. If you get any, if it gets any further than that.
That was the hardest part of the course. You've passed the rest.
all them numbers. You try spelling with them.
Oh, right. Okay. So the 5 sections have you got the handout with you?
Yes, sir.
Yeah.
So basically, the 5 sections that I've picked out that are relevant to us is understanding what first aid is and the fears that people have with performing first aid, why some people are reluctant to perform first aid. The next part is what we call the initial assessment, which is what happens when you first come across someone who's had an injury, whether it is someone outside who's had a heart attack, or whether someone's been kicked in the face in class and then knocked out, and you're now presented with what we call a casualty or an injured person. The next section we'll look at the recovery position and how it's used, when it should be used, when it shouldn't be used, and how it should be used. The next one, we'll look at cardiac arrest and CPR, which can happen to anyone. But if you have a student in class and you're having a sports class, for example, and so it's a cardio class, a fitness class, and they just drop, then you would assess that patient then with section 2 of this, which was initial assessment, and then you would assess what that is, and it could be a cardiac arrest. So that's why that's in our group. And the last one is just breaks, dislocations, and fractures, which are probably, other than bleeding, probably the most common in martial arts. Those 5 sections, we're just going to talk about them for 10 minutes each one, and that'll roughly, with the 5 question test at the end, 1 question from each of the 5, that should round up to an hour or just over. Okay, are we okay with that?
Mm-hmm.
Mm-hmm.
Good. Okay, so I've screen shared the PowerPoint presentation. You've told me you can both see it, so let's go from here. So you can read it, and I'll read it out, and stop me if you want to discuss anything. First aid can be a sensitive subject, and whilst there's no intention to offend people, if there is anything mentioned that's upsetting to you, or you need to take a break, just let me know. So we start. So this is the 10 minutes of the first part, understanding what first aid is. So what is first aid? Anyone want to have a guess?
It's like a first response situation where it's like there's like an initial, you want to make an initial assessment of what's going on and then act on what that situation is.
Yeah. It's the first help that somebody can get, or that you can give them, if you will. Yeah.
Brilliant. Good. So first aid is the initial assistance or care given to someone who's ill or injured, as you both just said. And it's aimed at preventing the conditioning from worsening or preventing further injury until the emergency services arrive and take over from you. So excellent, very good. So in first aid, first aiders are generally guided by the principle of the 3 Ps. So the 3 Ps in first aid will guide or determine a first aider's treatments and the order that they come in. Do you know any of those Ps?
No, I'm clear.
No.
So the first one is preserve life. So above all else, whatever's wrong with the patient, stopping them from dying is the primary that you're trying to achieve. The second, if there are no immediate signs of life-threatening issues, then the next issue is preventing deterioration. So, if they're in danger from something, trying to get them away from that danger, or if they're bleeding, trying to stop the bleeding, that kind of thing. And then the last one is promoting recovery. So if it isn't something too severe and it's something you can do to promote recovery, so it could be a splinter and you've took the splinter out and you've cleaned the wound and put a clean dressing on, So you've promoted recovery there, something as simple as that. Okay, we okay so far?
Mm-hmm.
So fears of first aid. Now, I've worked in this field for a long time, and for someone who works in that environment, like with any environment, you're confident of where you work. But for people who aren't, when they just hear horror stories of, even the mention of blood, it shocks some people. And so if they come across someone, like if you have two people sparring in class and they get a kick to the face and the nose just explodes, as it often does, or the lip, they get a cut lip and so there's blood all over the face. The tiniest cut, as you probably know, the tiniest cut can give the greatest amount of blood, just seems to spread. And even though it's a tiny cut, it looks a lot worse than it is. And so for people with no real training, that really has an effect on whether they will allow themselves to take part and do first aid. Even if they have first aid training, if they see a lot of blood, they start conjuring up, things which can stop them from helping out. So some of those things include being sued. They think if they try to help someone and make it worse, that they could be sued, and so that can be a fear. However, if you do decide to have a go, then a couple of ways to get permission, if you like, if the person is conscious enough and alert enough to be able to give you permission. The first thing you would do is introduce yourself. If they're stable enough to have a conversation, introduce yourself, ask them for permission to help. I know a bit of first aid, do you mind if I try and help? And if they're obliging and they're prepared to accept help, like on your membership form where you tick if you're happy to receive first aid or not, because there are some people, for one reason or another, whether it's religious or whatever, who refuse to have help. So if they say no, then that's it. There's nothing you can do. Help. And then, of course, activate the emergency services and then give the help that you're going to give. Does that make sense?
Mm-hmm.
Good. By all means, stop me if you need me to expand or if you want to tell me something. People are afraid that they can make things worse if they do something. So, they might think, oh, he's got a broken arm, and if I try to touch his arm, I could make the break worse, or I could do something else. So a rule of thumb is generally to stay within your training. So whatever training you have in first aid, stick within that. Don't be giving them a catheter, and don't intubate them and try and get a tube down so they can breathe. If that's outside of your skill set, then maybe avoid that. So other fears are a fear of being hurt. People think if they're hurt and I join in, I could get help. Can you think of a situation where if someone was in danger and they were being hurt and you helping them might hurt you?
If they were wired directly into the mains.
Yeah, exactly. So if you were going to try to move them, you'd have to move them with something that was non-conductive, wouldn't you?
Yeah, somebody else done.
Yeah. Or try to cut off the electric.
Just move them over there, mate, will you? There's two of them.
Yeah. So when you come across someone and you're thinking about what it is and what you can do, whether it's going to harm you or make them worse, there's a stop, think, act sort of phrase. Stop, take a few seconds, have a look around, think, decide what you're going to do and what you're capable of doing, and then act. So the first thing is call the emergency services, once they're on the way, you can then join in and do whatever it is that you're able to do. Put your gloves on, approach them, and so on, if you're carrying gloves. But most importantly, don't start out as a rescuer and end up as a patient. So if you think that it's going to put you in danger, it hasn't helped anyone by now having 2 patients. So don't put yourself in danger. Don't start out as someone helping someone and joining them as a patient. So fears is a big one. It really, whatever your skill set is, if there's always something there that's stopping you from having a go, these tend to be the reasons. And probably the most common one is fear of infection. So if someone is injured or ill or had an accident, more often than not, there's going to be blood involved. So in our case, so it could be you kick them in the face and their face is now bleeding, or you kick them in the chest, they fall on the floor and bang their face is now bleeding. You throw a kick and your toenail catches on a uniform, and as you pull your kick back, it rips the toenail back. Seen that before? You've got bleeding. So there's loads of opportunities for blood to be present in injuries, especially in our case. And so some of the fears for people about getting involved with blood is catching hepatitis or HIV. So people think if I go near blood, then there's a chance I've got a chance of catching one of these, and it's going to create issues for me, again making you a patient rather than a carer. So you should always use a barrier when possible. If you're dealing with any bodily fluid from one person to another, and treat all blood as if it is infected. Don't think it might not be. Treat it as if it is. Now, if it's in our class, of course, we have quite an extensive first aid kit. So if you were teaching a class, if I knew you were going to be teaching the next class because I wasn't going to be there, you'd be given a number of things, and one of them would be the first aid kit. So if you had to deal with something, you would have gloves and face masks and everything in that bag. So you'd have everything at your disposal. But most of us, even with my experience, if we go for a walk along the canal, I don't take a first aid kit with me. So if I come across someone, I haven't got any barriers. So you would have to give treatment that doesn't put you in jeopardy. So, if you're doing something to the face and they've got blood on their face, then you're not going to want to touch the face because you have to treat the blood as if it's infected. So there are limitations to what you might be able to do. But you would always primarily start with your call to the EMS, your 999 or 112, and get somebody out. How are we so far?
Mm-hmm.
Are we good?
Yeah.
Any questions, comments?
Well, I am sure I'm right when I say this, but if you was to find somebody hurt, if you don't have a cut on you, it's okay to touch blood, isn't it? As long as it won't go inside of you.
Not keen on that.
So if somebody was injured in a bad way and you didn't have anything, you could get hold of them and help them so they might not choke to death, and you can get blood on your hands and your skin. But as long as you don't actually have a cut, then is that not safe?
No. The simple answer is no.
Right.
You have to treat all blood as if it's infected, and there are so many blood-based infections, and it might not require a cut because your skin is porous. Things can get through skin without you having a cut. It's not the only way in. Or it could get under your fingernails, and fingernails have a blood supply. So you're already sort of open there. You don't want to put yourself in any situation where it's going to risk to you. If they've got HIV and you think you're covered and it gets under your fingernails and it gets into your bloodstream, then you've got HIV. or a very strong risk of. So you don't want to be tempting fate. If you haven't got gloves, just stay away from the blood. Even if you know the person, it's sometimes first aid can be hard because the good in us, the instinct in us, is to help, and sometimes you have to fight the fact that you don't want to end up a patient because you can't do anything for anyone then. So all you might be able to do is call the emergency services, keep the person comfortable, stop them from getting into any worse. Go back to your 3 Ps, so preserve life, make sure they're not in any immediate danger, make sure they're comfortable, and just try to keep them safe until someone else arrives that has the equipment that you don't. Does that make sense?
Yeah.
So, but if you are dealing with people in class, we're going from our class to outside now, so it's a little bit the information or advice is slightly different in arenas, So, if we bring it back to class a bit and make it first class related, you will have access to gloves and masks. So, and even with gloves and masks, you might still choose not to touch blood areas. There's nothing to say you have to do it. But if you had a choice between doing it with gloves or without, if you have access to gloves and masks, then I'd use those barriers. Does that make sense?
Yeah.
But you're right. It's hard though. You see someone injured, you just want to jump in and help. It is hard. So barriers, they're your primary concern. In class, someone has an injury, even if there's no blood, if someone's knocked out or they're just on the floor and they've hurt their leg or broke something, you might still always want to wear a barrier like gloves to protect them and you, because you don't know if you've got a cold coming on and you just haven't felt it yet and now you're transferring it to them. So if possible, wear barriers such as gloves and masks. Face shields. There are various types of face mask and face shields that if you have them in your first aid kit, which you will have because my bag will be there, then these are things that keep a barrier between you and the student or the patient that will facilitate you to be able to give them the treatment that you're trained to do up to the level you're trained to do and keep you, out of harm's way. Such as the face mask you can see there, which is a complete face covering one. So, you're far enough back to be able to put air in without anything getting to you because it has a valve, if that makes sense. But even then, there's nothing. If you were doing CPR, for example, and you didn't want to do what we call mouth to mouth, which medically is known as expired air resuscitation. If you didn't want to do the mouth to mouth because of whatever reason, then you could just do compression only. You could just do the chest compression only. And so you wouldn't need a mask. But if you wanted to do the mouth to mouth, then most first aid kits will have one of those shields, or at the very least, a mouth and nose mask that you might have seen that normally has oxygen going in.
From a point of view where you might catch something, is it safe to give mouth to mouth to somebody if you don't have a mask?
No, I wouldn't do it.
We'll go on to that in a second.
Okay.
But basically, whether the person has an obstruction in the mouth where you're unable to give mouth to mouth, or whether it's vomit, or because often, even in our class, you could do a back kick to someone to the stomach. The first thing they'll do is throw up. And then if they hit their head on the way ground or go into shock on the way ground or even have a heart attack and they're on the floor and they've got vomit on the mouth, you don't want to be giving mouth to mouth with that.
No.
So that's why the NHS a few years ago brought out compression only CPR, where you just the chest compressions, which are called external cardiac compressions, which is just your CPR. So no, you don't always have to. If you don't want to go near the mouth, you can just do the chest.
Right.
Okay, there's a nice picture for you there. Can you make that out?
Yep.
So an MMA fighter's gone to do a turning kick. The other guy's raised his knee and both his bones in his leg have snapped and his foot's now bending around the back of his knee. So there's your average injury in a martial arts competition. So easy. You're throwing a powerful kick with an unprotected limb. He raises his knee, and because the power has been stopped halfway up the leg, the power has to keep going somewhere, and so it snaps the bone and the foot carries on around to the back. So that's how simple, something can happen. So the initial assessment of that is quite simple, isn't it? You look at him and go, he's broke his leg.
Yeah.
So that's easy to determine. But in general, if it's not as easy to work out, or if they're unconscious and you're unable to talk to them, there's a mnemonic. And do we know what a mnemonic is?
No.
A mnemonic it's really good. It comes in handy all the time. You use the first letters of the words to make a phrase or a word to remind you of it. So the root of things that you do when you come across someone who's injured, if you look at the red letters on that slide, it's Dr. ABC.
Yeah.
So most people refer to it as Dr. ABC. Danger, response, airway, breathing, circulation, and they're the things that you're going to do in that order, whilst you assess someone. So the first thing you do is when you approach someone. So let's say you were teaching a class, and for some reason you didn't stop the class. You went to loo, you came back in, and someone's on the floor. The first thing you do is assess the danger. Is the person on the floor in any immediate danger? Am I going to be in any immediate danger by going to him? So it's not an electric shock. There's no cables lying around or broken glass or anything. He's just been kicked and he's lying on the floor. So there's no immediate danger. So you can now approach. So that's the D. And then response. If he's awake, then you can talk to him. What happened? Where does it hurt? That kind of thing. If he's not asleep, you can tap him on the shoulder or rub the shoulder and see if you can get a response or not. And then if his heart stopped and he's not breathing, then you would check the airway to see if there's an obstruction. And then after that, if he is breathing, then that's okay. And then if not, circulation, you could take the pulse. Generally, to take the pulse, there are just two ways. The first rule is never use your thumb. Do we know why?
It's got something, has it?
Yeah, it's got its own pulse, so we never use the thumb. So generally the first two fingers, and you can put them on this large artery that comes down here, which is called?
The carotid artery.
Excellent. Very good. So we put our finger on the carotid artery here. You can either put it up by the ear or down at the bottom of the V here and see if you can feel a pulse. If for some reason you can't get to that, then again, we've talked about this in class. You can take it in the wrist by pressing it on here. What's the name for this pulse on the wrist? Pete?
I've no idea, sir.
You're always telling me.
I'm really. Forgot it then.
The radial pulse.
Yeah.
No, I didn't know that.
Because the radial bones, the radius and the ulna.
Apparently I'm dead, sir. I can't find it.
So your radial bone and your ulna, radius and ulna. So the radius is on the thumb side. So if you feel just underneath where the wrist is, if you'll see where your arteries are, just in the center. If you press two fingers onto there, and you should feel your pulse. So that's how you're checking for circulation. There are other ways, but they're the main two. Okay, so initial assessment checklist. Introduce yourself. Awake, ask permission. If they're not awake, don't worry about permission. Just respond if that's not a clear thing to say. Don't try to wake them up to ask permission, really. So if they're awake, tap them, ask them, are you okay? Where does it hurt? Do you mind if I assist? I have some first aid training. They'll probably say yes, because they're scared and they're probably in shock and they just want it to be over. So then you would move into your ABC of your doctor ABC. So you'd open the airway by tilting the head and the chin back. When you push your head, your chin backwards this way, hyperextending the neck, it elongates the airway. What's the name of the pipe that we breathe through? Begins with a T.
Trachea.
Trachea, thank
you.
you.
Yeah, that's it.
The trachea is the breathing tube. So by pushing the chin back, it elongates the trachea at the top and just gives you a much clearer airway to breathe in. And then you're going to listen for breaths. When someone's on the ground and you're listening for breaths, you listen for 10 seconds. You're also trying to see, because you're putting your ear over the mouth and nose area, you're trying to feel if there's breath. And you're also listening for breath. And at the same time, because you're here, it actually guides your sight down their body. So you can feel for breath, you can listen for breathing, and by looking down the body, you can see if there's any elevation in the chest. So any of those things would indicate that the person's breathing. But you do that for 10 seconds, not just a couple of seconds. Any longer than that is, 10's enough. If they're not breathing, then the first thing you do is dial 999 or 112 from your phone if you've got a phone. Or if you haven't got a phone, then you scream loudly and try and get someone's attention so they'll come over to you, because you can't leave the person. Now you've found them, you're engaged, so you've got to scream for help and try and get someone to come to you. Although most of us carry phones, but if you haven't got one, you've got to get someone's attention. When they come over, if someone comes over, then you've probably started work at that point, in which case you need to be shouting to them, dial an ambulance. If you know, if you have any indication of what it is. So if you're in class, someone, you don't kick them very hard, but they were going to kick you at the same time. So they're stood on one foot. You do a reverse kick and hit them in the head. They then hit the floor, bang the head on the floor. Now they're knocked out. That's just the same as finding someone on the canal. So you don't know what's wrong. You just know that they're not, So you need to be doing your assessment, checking for breathing. And if they're breathing and you call 999, you can say to them, I suspect it's this. And then it gives them an idea of what to prepare for while they're on the way. They got kicked, they hit the floor, they've banged their head, they're unconscious. I don't think anything was broken. They haven't landed funny. I think they've just banged their head. They may, don't go into too much detail. It's not your job to do that. But by giving them a picture, painting a picture, then they'll know what they're walking into, and they can go from the generalization that you've given them. So if they're not breathing, get help and then start CPR. If they are breathing and there's no other concerns, we put them in the recovery position. So if that person in class has fell over, they've banged their head on the floor and they're unconscious, you check that they're breathing. They are breathing. Are they going pale in the face? Well, even if they're breathing, they could go pale because they could be in shock. But if you can feel breaths, you can see chest rising, and if you know how to take a pulse, which you now do, if you take a pulse and you know that they're okay, then it's nothing life-threatening in that way. You can turn them over into recovery position and leave them there until the EMS arrive. How are we so far?
Yeah.
Very good.
Good. Yeah. Any questions?
No.
No. Good. Okay. So call first, call fast is one of the things that we use. If we need to, I was going to say bleep someone. Then, if we need to call someone while we're out in the field, and it's defined as when a patient or casualty, sometimes the words are interchangeable and they don't use certain words, but if the patient isn't breathing and you're alone, then you need to call 999 immediately before you start CPR. If you've done your assessment and they're not breathing and you start your CPR, your chest compressions, and then you think, oh God, I haven't called for help, you're just going to be there doing that and no one knows you're there. So you've got to, before you start the assessment, get some help on the way and then go from there. I know some of these things are a bit, that's just common sense, but not everyone might. Okay, so the recovery position, we all know what that is, don't we?
Yep.
Okay. So if you find a patient breathing, this is if they're breathing and they're okay. From that point of view, it's not a heart attack. They haven't stopped breathing, and there's no immediate danger, no other concerns. You think that they're able to be moved safely, then all you're going to do is roll them into the recovery position. Check for immediate danger around the place. Make sure there's no danger. Make sure there's no injuries that would prohibit them from being put in a recovery position. And if they're wearing things like glasses or anything that's on the face, because they're going to be on their face, remove them, take them off, put them to one side. If they had, something hanging out their mouth or, anything on the face that's going to make things worse. Remember, you're promoting recovery. So because they're going to be on their face, you want anything that you can easily take off to be took off, such as glasses. Keep them warm and keep checking for breathing. So you've put them in the recovery position. You're waiting for the ambulance to get here. If there are any blankets, and I don't think I have a warm blanket in my first aid kit, so I'll check that, and if not, I'll have to update that. But generally, if you have a blanket of some type, then you can put that over them to keep them warm, because if they go into shock, they're going to feel cold. And remember to keep checking the breathing. You don't know what could happen at any time. Don't put them in recovery and think I can sit back now and wait. Keep an eye on them. Always be assessing them every couple of minutes. Check a pulse, or go down and see if there's check for breath while you're waiting. It says, as you can see, activate EMS. Turn over if longer than 30 minutes. What do we think about that?
I've never heard of that, sir. Never heard of that.
No. If it's an emergency situation, it's unlikely an ambulance is going to be more than 30 minutes. However, you never know. Traffic or something more immediate might come up. You can change them. You can swap them onto the back or the other side. But the guidelines, it's the same for, as you can see, the next one. Placing a woman. Avoid placing a pregnant lady on the right-hand side. So do we know why that is?
No.
Do we know why we shouldn't swap? Okay. You have a large vein that runs along the right-hand side of your spine, and it's called the inferior vena cava, which is a big name. It's just a name for one of the main arteries or veins that goes to the heart, and it's responsible for. It goes down, runs along the spine on the right-hand side, and it's responsible for taking blood from the body back up to the heart. And medically, you're advised to place a patient on the right side if you're talking about a pregnant woman, because the fetus is likely to compress. If you put a woman on the left side, the fetus will be lying on the inferior vena cava. If the baby is compressing the vein, like pressing a hose that stops the water getting through, it's going to decrease the amount of blood that can return back to the heart. Does that make sense?
Yeah.
So by turning the patient over who isn't a pregnant lady or is a lady who isn't pregnant, swapping her onto the other side might not be that big a deal, because, you know, I don't think they're going to be how long the EMS take. But from a pregnant lady's point of view, because they've got a heavy weight of the baby, when you put them on that side, the baby will rest on that vein, the inferior vena cava, and therefore reduces or restricts the blood flow back to the heart. So to recap, recovery position, 30 minutes on the right side, on the left side. But if you need to change them over to both sides, that's fine. But if it's a pregnant lady, then avoid placing them on the right side, because if you place them on the left side, it restricts blood flow returning to the heart from the inferior vena cava. That's very deep, isn't it? Basically, the why, don't worry about the why. Just think of it as a rule for recovery position. Avoid placing pregnant women on the right-hand side. In other words, always place pregnant women on the left-hand side, which you will start all recovery positions go on the left. Avoid putting pregnant women on the right-hand side. Okay, any questions?
No.
No, nothing for me. Okay. Sudden cardiac arrest. Sudden cardiac arrest happens when the heart stops. In most cases, the heart goes into ventricular fibrillation. Sudden cardiac arrest counts for 75,000 deaths just in the UK every year. And the survival rate for patients outside of a hospital suffer from a sudden cardiac arrest is about 5%. Just let that sink in. So the survival rate of people who suffer cardiac arrest outside of a hospital, the survival rate is 5%. Therefore, early and effective CPR is vital, but it doesn't guarantee survival. So if someone has a heart attack and you have some training, doing something's better than nothing. Don't become another victim, but if you can do something, doing something better. AED. AEDs are automated external defibrillators. They're carried by emergency medical people, community responders, and you may have noticed there's one at our hall. That was a government initiative where places where people gather, social places, now have AEDs placed outside. Have you noticed we've got one at our hall? No. Never noticed it? No?
Yes, I have done. It's outside on, isn't it?
It is, yeah.
Yeah.
So that's your AED. That's your, you know, when you see it on casualty, clear, that thing. So that's what an AED is. But basically, it used to be, you can do first aid courses that have AED as part of the training so that you know how to use them. But as time's gone on, the AEDs, particularly the ones at our hall, are automated. So you'll call 999, you'll say, I suspect cardiac arrest, they're not breathing, and they say, right, okay, we've got an ambulance on the way. It shows on our system that your building has an AED outside. Here's the code. They'll give you a code. You go outside, you punch the code in, and then you get one of those things on the screen there will come out. You bring it in, and it's a very clear, very simple diagram that tells you where to put the two pads. There's two pads. You put one on the chest and one just on the side underneath, and then it'll tell you to press a button, and then you step back and it'll count down 3 seconds to shock or 5 seconds to shock, and then it'll go boom. The person will raise off the floor about 72 feet. Well, no, maybe about 2 or 3 inches, and then back down, and then that's delivered an electrocardio shock to the heart to try and give it, to try and restart the heart. For people with more knowledge, more in-depth clinical knowledge, although it's not really used anymore, there used to be a thing called a PCT, which is some people call it a precardial thump, some people call it a pericardial thump, and it's basically just when the person's lying there, you do a bottom fist strike straight into the center of the chest to give the same effect as an AED, to give a jump start, to try and get the heart pumping again. And once there's a little bit of electrical activity within that cardiac muscle, the heart muscle, then you can start your compressions to start getting the blood pumping again, and then the person's back with us. Wonderful, isn't it?
Can I just ask, sir?
Yeah.
Right, what happens, right? You find this patient on the floor, whatever, and you determine that they're not breathing. So but say they got extra shallow breathing, and you can't find a pulse. If you use one of them machines while they're actually breathing, would it do them any damage?
I think if you're...
What happens if I get it wrong and I use one of these things?
If you're listening for breathing and you're trying to feel breaths and you're looking for chest elevations and you can't see any of those, and you make the determination that they're not breathing, you'll soon find out if they are, because they'll either choke or they'll cough, because you're trying to push air in and they're already breathing. So you'll quickly see that there's a fight. There'll be a conflict between the air you're trying to put in and the air the lungs are already working. So you'll see that quite quickly, and then you'll stop. But it's very unlikely that it's that shallow that you either can't feel a pulse. Generally, you won't feel a pulse, but you'll see the chest, or you won't see the chest, but you'll feel the breaths, even if they're very faint. If you don't see all, if you afterwards, if you say there was no chest elevation, I couldn't feel breath on my face, I took a pulse I took a carotid pulse and a radial pulse and couldn't feel any pulse, so I determined that they were in cardiac arrest, and so I started CPR. It's better to do something than nothing. But if they are breathing, you'll find out soon enough.
Mm-hmm.
Okay. So single rescuer CPR. So you're teaching a class on your own. No other first aiders in the room. So you have to deal with it yourself without a partner. Often the most scariest part, because everyone's standing around looking at you saying, go on, save him. And you've got to do it all. So you've got that to deal with. You've got people shouting at you, you're doing it wrong, you're doing it wrong.
Yeah, quickly.
Or you're doing CPR.
I'm in a test.
Quickly, I need to show you something.
No, I'm not coming. No.
Look, it looks like our aftershave because it says Gucci.
Right, very good. Sorry.
Yeah, so you've got a crowd standing around you. You're doing CPR, and all you can hear is ribs breaking, and that you're killing him. You're breaking his ribs. You're having to deal with them shouting, and you're thinking, God, am I killing him? Am I making things worse? But the fact of the matter is that if their heart's not pumping, they're already dead. You can't make anything worse. All you can do is make things better. And if you get that heart started, then you can heal from broken ribs. Can't heal from dead. So that's why better to do something than nothing. So you're on your own. You've approached barriers, introduced, tapped, and shouted. So no response. And so you've tilted the head, as we've discussed, in order to make what does tilting the head do, James?
It makes the airway straight, if you will.
Yeah, clearer, perfect.
Yeah.
So you're checking for your breaths, 10 seconds listening for breaths. There's no breaths, they're not breathing. You've looked down the chest, you've took a pulse. Definitely no breathing going on as far as you're concerned. So the next thing you do is call or get someone to call the emergency services. And when you speak to the emergency services, they'll tell you. You won't need to tell them. They'll know that there's an AED on site, and they'll tell you a code and to go and get it. There's no problem with keeping them on the phone. If you're unsure about anything, whether it's how to do CPR, if you've suddenly forgot because you're in shock yourself, or you're nervous because people are watching, or you don't know how to use the AED, keep them on the phone and they'll guide you through it. You don't have to do it on your own. Chest compressions. This is a little mathematical and confusing, but after you've done it for a while, it just becomes second nature. There's only a couple of things to consider. The first and most important is the ratio of chest compressions to mouth to mouth. So basically, if you are doing mouth to mouth and not just chest compressions only, it's a ratio of 30-2. So if you're on your own, there's no blood, there's no vomit, there's no obstacles, no foreign bodies, so you're happy to do mouth to mouth, then you will do 30 chest compressions. You will stop and do 2 breaths, and then you will go back to 30 chest compressions, and you will keep going at that ratio, 30-2, until one of 2 things. Either you ask somebody else to take over because you're knackered, and you will be. Ideally, every 2 minutes you would get someone to change, or you'll keep going if you're on your own, however tired, until the EMS arrive and take over. The 2 other things that go with that 30-2 ratio is, what speed do you do the thing? Now, in a clinical area, we're taught to think of it as 100 to 120 beats per minute of the heart. But
you believe the song that one of Staying Alive is the right beat, isn't it?
Correct. Well, this is the thing. That's what the government put out in that advert. So if you were in a clinical area or a clinical skills lab, and they'd be telling you that you're looking at 100 to 120 beats per minute in your chest compressions. But if you don't know what that means, I don't know if you've got a Walkman on or where you're going to find that song. But if you've got access to that song while you're walking along the canal, then yes, or sing it out loud or whatever it is you need to do. But if you know that song and you can sing I don't know how silly you'd look, but no one cares how silly you look. But if you can do that, then yes, that will keep you to an average of 100 to 120 beats per minute. So your compressions need to be, at a rate of up to 100 plus per minute. It's not 1, and it's not slow, and it's not really fast. A heart rate, a heart pump rate of 100 to 120. And the only other one is the depth of the push. So in an adult, we're talking about adults here because we're talking about the adult martial arts class, then you're looking at 5 to 6 centimeter depth of the push. So when you interlock however you have your hands, when you're doing your pushes coming down, you want a depth from the top of the chest down into the chest of 5 to 6 centimeters. So the chest compressions is a ratio of 30-2. That's 30 presses for 2 breaths. You want those presses to be at a speed or a rate of 100 to 120 beats a minute. And you want the depth of those pushes to be 5 to 6 centimeters. Okay?
Mm-hmm.
Are we happy with that?
Yeah.
Yeah, good.
It's funny, really. So, some of them programs I watch, there's one called The First 48. Have you ever heard of that?
No.
It just follows police in America going around solving crimes. My daughter bought it on the DVD. There's like loads of them, but I did notice actually that when the detective, it's all live and it's all real. When the detectives get there, and there's a body on the lawn or there's a body in a bathroom or something like that, and the emergency services have already been, there's always like loads of gear, loads of tubes and pipes to try and get him going again. But every single time when it gets into somebody coming out, just checking them over and going through it with the police, always they said that the ribs have been broke.
Yeah.
By the emergency services doing it. So they get stuck in proper when they're doing it, and every single one they come up, yeah, they just go through it, yeah, his ribs are broke, but that's nothing to do with the murder, like, you know, he's always got half his head hanging off, or but a machete stuck in his throat. But first thing they always say, his ribs are broke, but that's nothing to do with it, that's the emergency services doing it.
It's common, and the people who have had heart attacks and they're in hospital, in their recovery phases, the majority of significant pain that they're dealing with post-event is chest pain as a result of broken ribs. But like we've said, you know, the ribs will heal, at least they're here. But yeah, very common for ribs to break in CPR because you've got to get that depth in order to reach the heart and compress it enough so that it can pump the blood. So, but yeah, common. So we've covered that. 2 breaths. So if you are doing the mouth to mouth, what we call expired air resuscitation, when you tilt the head back in order to lengthen the trachea, the air pipe, you're going to be breathing into the mouth. If you don't pinch the nose, if you leave the nose open and breathe in, it's going to come out the nose, if that doesn't make sense. So you must make sure that when you tilt the head back, you pinch the nose so that when you make a tight seal with your mouth over theirs, the only place for your air to go is into them, not out the nose. And you want your breath to last for a good second. It's not a quick blow like you're trying to blow someone over. It's an exhale. It's a force of air in. You're trying to fill the lungs with oxygen like they're taking the breath. If the breath doesn't go in, if you've pinched the nose, you've pulled you've tilted the head back, you've made a tight seal, there's no air escaping, but when you push your air in, for some reason, your own cheeks are expanding, you know, like you're about to blow a kiss or something. It's because the air isn't going in. At that point, it's fair to assume that there's a foreign body in there, and the mouth or the throat is obstructing. So, you know, they could have been chewing on a sweet or something and suddenly had a heart attack, and now the sweet is lodged in the throat or the mouth. So that could be a thing, a reason why the air is not getting through. Repeat 30 to 2. We've covered that. Don't waste time between compressions and breaths. In other words, don't do your 30 compressions, sit back, take a rest, and then do your 2 breaths. I'm glad you're laughing at that, because some people think, why? It must be consistent, one after the other.
Well, I just thought I'd scroll through Facebook, and then I'll do breaths when I'm finished.
Yeah, I'll just check this email. Yeah,
I'll just have a quick brew. I just have a quick brew, and then I'll be back.
Yeah, I've done the 30. Yeah. If the patient is sick, turn them onto the side and remove the vomit. If you're happy to do so, at the very least, turn them on the side so we can drain out on their own. If for some reason the mouth is damaged, if you're in class and it's been a kick to the jaw and the jaw is dislocated, and you don't feel happy to pull the chin back to create a space for you to breathe into, then you can try to put your hand across the mouth without applying pressure if it's a break, and then pinch through the nose. Where you lift up from the chin and then pull the chin back, normally to go over the mouth, if you were going to go through the nose, you'd use the fingers to keep the chin up. But really, you don't want to be applying any pressure there if you think it's a dislocation or a break. Just perhaps go to your chest compressions only. If the mouth-to-mouth is difficult, or you're in water and you can't get a good seal, that doesn't apply to us. Agonal breathing. Are we okay so far?
Yeah.
Okay. Have we heard of agonal breathing before?
Never heard of
No.
it.
This is generally something that is only seen in a hospital, and it's as common as, common things, if you're
It's common, something that's very common.
it's relatively common, I would say, as common goes. But yeah, I'm trying to think. It's as common, perhaps, as sneezing or yawning in a clinical environment. This is what it is if someone is breathing in agonal breathing, they're not breathing. They've passed away, and that breathing is air leaving the body. But it sounds like someone. It sounds like breathing, although it sounds weird. It's a very distinctive sound, but it's called agonal breathing, and basically it's air leaving the body. So agonal breathing is a gasping sound, not like normal breathing. Agonal breathing is a sign of death, not of life, and it's a very definite sign that CPR is needed. So you'll know it when you know it, and when it's there, that if you've got someone on the floor and they're making a very weird breathing sound, like a gasping, but not like a gasping for air, it's a weird, deep, sort of bellowing kind of breath, you'll know CPR is needed immediately. It happens in about 40%. I'd say it's a bit higher than that, depending on where you work. But this says 40% of cardiac arrests. It happens in 100% of cardiac arrests if you're around cardiac arrests all the time. But it's very common and it's very distinctive. So a recap of single person response. You come across someone in class or outside, they're unresponsive. You shout for help, and if they wake up and they're responsive and they're talking to you, then just sit them up, keep them comfortable whilst you get help to come. If they're unconscious but breathing, you're going to put them in recovery position. If they're not breathing, assuming no one's in any further danger, if they're not breathing, again, call the emergency services first, and then get them into a position, get yourself comfortable, and begin your CPR. What was the rate of breaths to chest, James?
3 on the chest and two breaths.
Perfect. What depth of compressions, Pete?
5 to 6 centimetres.
5 to 6 centimetres, perfect.
5 to 6.
Can I just ask you the stupid question of the day, sir? What does CPR stand for? What is it?
I should have said that a while ago, shouldn't I? It stands for cardiopulmonary resuscitation.
No, I know.
And it's an old term, really. It's not. People still use it now, and it refers to, or it relates to, mouth to mouth and chest compressions. Cardio and pulmonary. Cardio is heart and blood, and pulmonary is lungs and breathing. And obviously, resuscitation means restarting. So if someone has a heart attack and they're not breathing, then their heart isn't going to be pumping. And so you need to resuscitate that, which means restart it. But CPR isn't really an accurate term these days, because a lot of people won't do the mouth to mouth. They'll only do the chest compressions. So it's not CPR because they're not doing the P. They're just doing the compressions. Two breaths. Okay, that's good. Why compressions only? Well, we've covered this. There might be facial trauma. So in our case, someone might have been kicked in the face and the jaw's dislocated, and the nose might be broken, and so you don't feel you can get a good seal, particularly if the nose is protruding out through the skin, or the jaw is protruding out. Or again, in our case, if it's a back kick and there's vomit or stoma, there's an obstruction in the mouth, and you don't feel that air could get through, then you would just do the chest compressions. Chest compressions are still done at the rate of whether you're doing CPR or not, or just chest compressions, still 100 to 120 at 5 to 6.
If you was gonna do it with breaths as well, is it better to do the breaths first and then the chest, or the chest and then the breaths? Or
start. The first thing you do is call your EMS and then go straight into chest.
Right, chest and then the breaths then.
Yeah.
Right.
Does that make sense?
Yeah.
Do you think it should be straight to mouth first?
Well, I wasn't sure. I didn't know it because if there's no air in them, then if you were to put some air in them, then it's in them whilst you're on the chest.
What do you think?
Ultimately, if there was to not want it in them, I am sure you'd know, wouldn't you?
Yeah. What do you think, Pete?
If you're acting as a trigger for that pump, that's your heart, as soon as I suppose that'd be the way to go first. I suppose, if you check the mouth for debris and all that business, but I would hit the chest first, because that's where the pump is. That's what you're actually, while the heart's not working, you're providing that pump to get the blood through, which keeps the brain alive.
It's mouth to mouth first.
Is it?
Is it?
No breath, no life.
No.
First thing you do is get the air into them, and then you can start the compressions. If you're breathing into them, you're putting air into the lungs, and that air will go into the blood.
I've murdered at least 4 people then.
Terrible, wasn't it? Trick question. I just thought that's where we were up to.
Yeah.
No. So to answer the question, it is after you've called the emergency services, it's get some breath into them. Get the breath in first, then go on to the chest. As long as you're putting breath into them and putting oxygen in the lungs, then the heart can start pumping. If you pump the heart first and it starts pumping blood, there's no oxygen in the blood, so it's not doing anything, is it? So you've got to get that oxygen into the lungs and then get the heart to start pumping the oxygenated blood around the body. Does that make sense?
So what happens if they're a particularly horrible person with all sores around the face and all that? Is
well,
that...
like grot bags off program.
Whoever, you turn her over and she's like Wicked Witch of the West, full of sores and all sorts of horrible things. So,
well, we're such nice people, we wouldn't care, would we? We just want to help. Right.
I mean, I'm on about that. Is it not just? Can you not just carry on with the chest compressions without? Nobody habitually carries about one of these things. You can like breathe, like one of these one-way valve things.
No, they don't. No. So you just, if for some reason you don't want to do mouth to mouth, you would just do your chest compressions. Ideally, you would start with the mouth, but if for some reason you can't do that, then you would start with the chest. But ideally, if you get the heart pumping, then it's going to want to get air in. But ideally, you would kickstart that by putting some air in, like putting a bit of petrol in your engine, and then try to turn it over. So CPR handover, if you're not on your own, it's recommended that if you both have some training, or even if you haven't, if the person who's with you doesn't have training and he's watching you, he can copy you and take over from you. And the recommendation is to change over every 2 minutes. And then you can instruct the other person if they Okay, bleeding. This is ways of telling. This isn't necessary information for a first aider, but it would be good if you knew this. It's good so that you can pass this on to the emergency services if they ask you questions. There are 3 types of bleed from a person: an arterial, a venous, and a capillary. Obviously, artery, veins, and small, very small capillaries. If it's an arterial bleed from an artery, it's bright red and it pumps very quickly and very hard. If it's blood from a vein, it's dark red and it seeps out and it's slow. And a capillary bleed oozes and is easily stopped and pressed. So if you knew that, you could say when you called the emergency services, the bleeding from they've broken their arm, the arm is protruding out of the skin and they're bleeding, the blood is bright red and pumping. So they now know that they can, how they can prioritize you because they know that your patient is bleeding from an artery, which is more life-threatening. So it just helps them with what they need to do next. An internal bleed, which you might not be able to see for the majority of the time, you should treat that by dealing with shock. But we won't go into shock today. It would take too long. So the initial assessment for the secondary injury of a conscious person is to see if anything else is wrong. So we call this a top-to-toe survey. So if you have a student in your class, they've been kicked in the face, they've knocked a couple of teeth out, and so there's a lot of blood in the mouth, and so you're dealing with that. You've got them sat down, you've cleaned them up, you've put a compression on the blood, on the gum to try and suppress the bleeding. And then while you're waiting for someone to come, if you've called emergency services, then you would do a top-to-toe survey to see if there are any other injuries that were a result of them either being hit a second time or falling over and banging something else, that kind of thing. And basically, it's for things like that where the patient is awake or the student is awake. It's things like talking to them all the time, asking them questions, keeping them alert. If they're losing blood or if they've banged their head, not letting them go to sleep, that kind of thing. Just making them feel comfortable, keeping them warm, and then get somebody else, if there's somebody else there, to write down some notes, find the accident book and start getting some details in there. What happened? When did it happen? What treatment was given? That kind of thing. Okay. Breaks. So breaks, probably the most common one for us. Basically, there are 3 types of breaks. There are more complicated names, but basically you've got a closed break, which is where a break happens inside the body. So you kick someone in the chest and break a rib. So that's a closed break because it's inside. An open break is if you block a kick and they hit your arm so hard with the side kick that the bone comes out the other side and it's protruding out of the skin. That's an open break. That will also incur blood loss because there'll be blood escaping from the body. And then there are complicated, what we call complicated breaks, where nerve damage is included. So as well as the break, the nerves around the bone could be affected. So if it's a hand, for example, if you punch something hard and you break the knuckles and it also digs into a nerve or severs a nerve, then you've got a complicated break. So they're your 3 main ones. Treatment for breaks. There's not much you can do as a first aider. They need medical attention for the majority of the time. The treatment is basically just to immobilize whatever it is that you suspect might be broken or injured. If you have access to splints or slings or anything that can help to keep it immobilized and still, you would use them. If not, if it was their arm, for example, you'd just get them to put their arm on the chest and then hold across with the other arm just to immobilize it, just to keep it still. That'll minimize pain and maybe inflammation until somebody can get there and then take over. With dislocations, they're a little simpler. And And again, they're treated like brakes. You know, they can be immobilized, or if you have the training, if it's a shoulder, for example, or an elbow, you know, they can be popped back in. Shoulders pop in and out all the time. They're quite painful unless it's a very regular thing for you due to a condition. They could be condition related, but they're treated similar to brakes in that they're immobilized and then they're shipped off to where it can be treated. And that's the end. How super simple was that?
Mm-hmm.
Just remember it and then practicing on some unfortunate.
So, okay.
It sounds like we're going to be practicing on James. What's that coffee you've got there, boys?
Yeah, I know. It's
Oh, right, okay. So now I'm going to ask a question from each section. I wonder if I can think of one each. James, what's first aid?
It's the first help which you give to somebody. And basically the idea is just to help them to a point where they won't get worse and call for help.
Good. Pete, what's one of the 3 P's?
Preserve life.
Very good. On finding a person injured, we use Dr. ABC. What does the A stand for, Pete?
Airway. Is it Airway?
Correct. Yeah. And
Airway.
C, James?
Circulation.
Very good. If we put someone in the recovery position, James, do we take glasses off or leave them on?
Off.
We take them off. Good. Okay. And Pete, if we put a pregnant lady in the recovery position, do we place them on the right side?
No, left side, sir.
Excellent. Pete, give me a reason why we might not give mouth to mouth.
Fear of transmission. If there's any blood there, fear of transmission.
Good. Okay.
And one would be if the face has been like smashed itself. So but it's not safe to touch his face, is it? Or their face, I should say.
Perfect. Okay. And James, what's a closed break?
A closed break is a bone that breaks, but it stays inside the skin, if you will.
Okay. And Pete, in the treatment of a break, what's the simplest treatment?
Simplest treatment?
We just...
leave it alone, I suppose.
Yeah. Yes, we keep it still. How do we keep it still?
Immobilize it.
Immobilize it. Perfect. Excellent. And that's that.
Get away. Very good.
Well, we all passed.
Good job.